So today's topic, neurological manifestations among patients hospitalized with COVID-19. What have we learned and where do we go from here? So I have tried to divide the whole course into these outlines. We'll start with the pre-course evaluation. That is around like 10 questions, and I would recommend not to spend too much time on that, because the purpose for that questions are to learn the questions as we go along. And then I'll touch some basic historical background, neuropathogenesis, some relevant published papers. I'll try to show some neuroimagings and recent publications about the incidence and outcomes associated with and neurological manifestations. Following that, those would be the lecture slides. And following that, I'll have 5 cases to consolidate what we've learned on those 20 slides beforehand. Followed by, I'll try to talk about the multi-system inflammatory syndrome in children. That is upcoming topic. And then we'll show some videos, and we'll try to end the evening with the post-course evaluation and some question and answers. So I'll go ahead and give you guys the link to the pre-course evaluation. So here we go. I would recommend you guys to go ahead and fill this out now. You can just click on that link and probably you'll get to the form. If you are not able to access that, let me know. Esna, can you access that form? Can you check, please?
Yes, sir, it's accessible.
Can you?
Yes, sir.
Okay. Let's take a 5 minutes time for this. Moderators, please monitor the time. And then we'll start with the slides. Now let me know when it's 5 minutes, okay? Or Pradesh. Thank you. This pre-course evaluation and post-course evaluation is important for us for the future lectures so that we can improve upon that. And we also need to submit this to the Nepal Medical Council for us to give you the Cpd points. So please make sure all the folks who are joining later scroll up and click on the link to fill out the pre-course evaluation even during the lecture. Are we ready, Esna?
Yes, sir. Now we have completed 5 minutes.
All right. So let's move to the historical background. So regarding the historical background, so there are multiple preliminary clinical data that have indicated that SARS coronavirus type 2 infection the neurological complications of SARS have similarities to those that were described in previous coronavirus epidemics, which were in 2003 when the SARS happened. That is the variant of coronavirus type 1. And in 2012, which is the MERS. These viruses also demonstrated the neurological findings similar to what we've been seeing with the COVID-19, which include encephalopathy, encephalitis, and strokes, which are either ischemic or hemorrhagic types, and along with the peripheral nervous system disorders such as Guillain-Barré syndrome. However, number of infected individuals at that time were much more smaller with the SARS 8000 and MERS 2500. So given the pandemic now, we are expecting to see a lot more numbers of neurological manifestations. So these are some of the relevant papers that I picked for today's talk program. There are 6 of them, along with the 2 papers that has mentioned about the pediatric multi-inflammatory syndrome in children related to COVID-19. I'll discuss each and every paper important points along with the tables and graphs. So first, we need to understand about the neurotropic coronaviruses. The coronaviruses are RNA viruses, and they are divided into 3 genera: alpha, beta, and gamma viruses. Currently, there are 7 coronaviruses that can infect humans that has been identified. I don't need to, all right, I'm not going to take the names of they are here. They are listed here, and the slides are going to be available for all of us folks. And then the beta coronaviruses has coronavirus type 1 that had produced the SARS and MERS, and coronavirus type 2, which we are seeing with the COVID-19. When I meant coronavirus, I would be implying for the COVID-19 SARS-CoV-2 virus during the entire presentation. So there are other 3 variants of the coronaviruses that has been shown to infect the neurons directly, and those are 229E, OC43, and coronavirus type 1. And interestingly, if you look at the OC43 variant, that has also been found to be involved with the multiple sclerosis based upon the presence of viral RNA in the autopsy of the brain tissue of the donor who died with the multiple sclerosis. So we're going to discuss about the neuropathogenesis of SARS virus now, or coronavirus type 2. So there are several ways that this virus can get access to the central nervous system and peripheral nervous system. The first route is through the neuropharynx, where they come in direct contact with the clavicular plate and they pass through and then infect the olfactory nerve and go to the brain. Second type is the virus coming directly into the lumen and then affecting the vascular endothelium. Third type, the leukocytes brings the virus along with it, and they can pass through the blood-brain barrier. And the fourth type would be the endocytosis process, where they have a fast axonal transport mechanism, and then coronavirus pass through this and then infect the neurons. Interesting finding is, as you can see on this picture B, where leukocyte brings the viruses, they pass through the blood-brain barrier, affecting the astrocytes. And this mechanism has been seen in the previous HIV infection or HIV encephalitis, and we term this as a Trojan horse mechanism. So now we learned about
Sir, you are not audible.
uh, hello?
Yes, sir, you are audible now.
Have you guys been hearing me or no from the very beginning? Hello?
Yes, sir, you are audible now.
Oh, so do I have to restart the whole thing?
No, sir. No, sir.
Okay. So did you guys hear until here? Did you guys understood me until this slide or no?
Yes, sir.
Okay. So moving on. Uh, so neuropathogenesis. Now, since we learned how the virus can access or route to the central nervous system, we need to understand how these viruses attach or how do they get into the receptors and they get themselves there. So, so ACE2 receptor has been shown to be expressed widely into the multiple cells of the epithelia, lung parenchyma, and vascular endothelium throughout the body and widely throughout the CNS. They have also been shown to be expressed in neurons, astrocytes, and oligodendrocytes. Expression of ACE2 was seen to be very highly concentrated in certain areas of the brain, such as substantia nigra, ventricles, middle temporal gyrus, or posterior cingulate cortex. And they have been also been found in the motor cortex and neurons and glial cells. They were, and the neuronal cell culture, what we saw was ACE2 is also expressed on the surface membrane as well as in the cytoplasm. So this kind of raises the concerns that widespread ACE2 expression in the brain could have the potential to infect the neurons and glial cells in the similar manner, the way it had, the way this COVID coronavirus type 1 had infected on the previous SARS. So this is the picture where I think somebody has the line drawn here. Moderator, could you please check that somebody has access to the lines drawing on the slides? Okay, so this is the picture that kind of explains where the brain tissue has ACE2 receptors mostly abundant. We can see that in the motor cortex here, posterior cingulate cortex, as well as substantia nigra, middle temporal gyrus, and brain stem. And these are the cells of the brain which has expressions to the ACE2 receptors. And this picture is very interesting down here in the bottom, which says that there's a spike protein binds to the ACE2 receptor here, and they get primed by the transmembrane protease serine 2, and then they can infect the neurons. So we've learned that how the virus get access to the receptors. Now let's look into this table where it tells about the diagnostic, clinical presentation, and neuropathogenesis. This purple bar what you see here represent when we do the PCR testing around 6 to 7 days, they become positive, and followed by IgG and IgM, which kind of comes around after 7 days. But clinical presentations comes a lot earlier than that, with the cough, fever, tiredness, myalgia, headache, encephalitis, and myelitis, including ADM. And the Guillain-Barré syndrome is here even earlier than that, and the stroke, and then direct viral infections and para-infectious and post-infectious. So this is the line somebody has drawn. It's not me, so ignore that. So now the interesting point on this slide is thinking about the IgG antibodies. You know, how long the IgG antibody production can take, or how long do they last after the initial infection? We don't know exactly, but with the analogy with other viruses, we can expect that it may persist for more than 3 to 6 months. Okay, so let's move on. So if you look at the, this is the emerging spectrum of the COVID with the clinical radiological findings. This was the table that is adapted from the brain that was published last year, which is showing that they've tried to divide it into the 5 categories here. However, the categories has increased recently. So they have encephalopathy, inflammatory syndromes of the para and post-infectious, and then stroke, peripheral syndromes, miscellaneous types. And then this is the age of the patients that they presented with, and there were only 43 patients at that time. And then main clinical features were delirium, psychosis on the encephalopathy part, and similarly, they presented with the multiple syndromes or symptoms at the presentation. The interesting part here is another one is they were all positive with the PCR on the nasopharyngeal swab, but they remain negative with the PCR on the CSF itself. Most of them had a complete recovery, or one of them had a complete recovery. Is there someone who is drawing this line and not being able to do that? Can somebody stop this drawing line, please? Or I will have to restart the talk with another slide. Let me try to do that, probably. Let me try to restart the slides. I'm sorry, but somebody's fooling around with the slides. Okay, there we go. Can you guys hear me? Hello?
Yes, sir.
Yes,
Okay, good. All right, so if you look at the treatments here, we can see that the treatments were mainly supportive and were treated with the corticosteroids and low molecular weight heparin with the IVIG and IV steroids. Most of them had a good recovery. Wow. Somebody doesn't want me to talk, things like that. All right. Is there a way that we can stop this from happening, or how could we do it? Can we figure that out, guys?
please cooperate. Don't do such unnecessary activities. I request you. If you do not want to attend the meeting, then you may be. Please don't do that.
So let's go and look at the axis here. And probably we can just get those folks out. And do you guys know how to do that? Anybody? Any volunteer among the participants?
Sami, please can you disable this?
So you can go after you start sharing screen, you can go to more and disable annotations from participants.
How do I do that? Go to where?
After you start screen sharing, on the top of your screen, you can go to, we can click more, and there is an option called disable screen annotations.
Okay. After starting the screen sharing, right?
Yes, sir.
Okay, thank you. Let me do that. Where is it? There's an annotate here, but I don't see to disable it. And the more?
Under more, there is disable participants annotation.
Okay, here you go. I did that.
You
All right.
Nobody will be able to.
Thank you so much. That was really helpful. All right. So I talked about this slide already. So let's move on to the paper that just came out on May 11th, 2021. So what are the incidences and outcomes associated with the neurological manifestations in the patients with COVID-19? So here, this paper kind of talked about 2 consortiums. One was from the European Academy of Neurology, which is the Energy Consortium, And another one was a global consortium study of neurological manifestations COVID virus. So on this, the report of the GCS consortium and Energy consortium, they found that with this cohort study of almost 4,000 patients, there were two large consortia that showed pretty much 80% neurological manifestations among the patients that were actually hospitalized. The most common self-reported symptoms were headache, anosmia, and ageusia, which is a loss of smell and loss of taste that we already know. And then most common neurological signs and syndromes were acute encephalopathy, coma, and stroke. Those were the signs and syndromes that were observed by the physicians. So this table is adapted from the same paper, and you can see what I just talked about is self-reported neurological symptoms has a headache, anosmia, ageusia, and syncope. One of the doctor was asking me here in Nepal, was that could it be possible? And I'll talk to you about why syncope is possible in the COVID-19 cases, because they also do dysautonomia. And most common clinically verified neurological sign or syndrome was encephalopathy, which was very common on both the groups, and then followed by strokes, coma, seizures, and dysautonomia, and then other manifestations started presenting now, with the most common also being the new movement abnormalities. This is a little bit different than the table that we saw first from the brain paper, because they had only categorized them in only 5 categories, but we have now even more categories to look at. And these are the characteristics associated with patient who died in the hospital due to COVID-19 infection. So if you look at this, I've tried to highlight the table so that for the proper understanding, and just to keep the very busy slide to minimum, the race was very common. The mortality was very high among the patient with the white race, and then subsequently less than other races. And that was also attributed to the pre-existing neurological disorders among those patients. This was from the European Academy, Energy, and another one is from GCS. And then if you go to the neurological signs and syndromes, the encephalopathy was always high, as you can see. And then followed by other categories that I already talked about. So to summarize these consortium studies, they actually, the presence of these clinically captured neurological signs and syndromes was associated with increased risk of in-hospital death after adjusting for study site, age, sex, race, and ethnicity. Presence of pre-existing neurological disorder was associated with increased risk of developing neurological signs and or syndromes with COVID-19. What was the conclusion and remark was, in this multi-cohort study, neurological manifestations were prevalent among the patients who were hospitalized with the COVID-19 and were associated with a higher in-hospital mortality. And then pre-existing neurological disorders were associated with increased risk of developing neurological signs and or syndromes in COVID-19. This is what we've summarized on these 2 consortium studies. So now we've learned a lot about the starting with the pathogenesis, receptors, and clinical characteristics, diagnostic, and other manifestations. Now we will try to consolidate what we've learned with the 5 cases that will come along. Okay, so we'll try to answer any questions if you guys have during the after the presentation, since I think we're running a little bit behind. But anyways, so let's get started here. The case 1 was about a 55-year-old woman with no previous psychiatry history who presented with a 14-day history of fever, cough, muscle aches, breathlessness, as well as loss of smell and reduced taste sensation. She required minimal oxygen treatment to 94% in room air and was well on discharge 3 days later. The following day, her husband reported that she was confused and behaving oddly. She was disoriented and displayed ritualistic behavior, such as putting her coat on and off repeatedly. She reported visual hallucinations, seeing lions and monkeys in her house. She also developed ongoing auditory hallucinations, persecutory delusions, Capgras delusions, and complex systematized delusional misperceptions. These are fancy psychiatry words. Most of you guys have already known. But she displayed intermittent aggressive behavior with the hospital staff and her family. Her psychotic symptoms persisted even after the disorientation improved. So the D-dimer was very mildly elevated. All the brain MRI, EEG, and lumbar puncture CSF studies were normal. Her clinical course fluctuated over the 3 weeks and with a trend towards improvement, albeit after the introduction of aldol and risperidone. The one thing that I noticed on this case that I adapted from the Brain and Lancet, they did not mention about the COVID-19 test, but at that time it was a very high pandemic during the first wave, so probably they presumed it is due to the COVID-19. And the diagnosis of the case was acute parainfectious encephalopathy with psychosis. Case 2, 65-year-old woman with a 2-year history of cognitive decline and presumed sporadic early onset Alzheimer's disease. They presented with a right hand and with then widespread involuntary movements. She reported having fever, cough, and myalgia 6 days before. She had difficulty speaking and became disoriented and confused, complaining of well-formed visual hallucinations of people inside her house and objects flying around the room. She complained of deteriorating vision with difficulty reading and intermittent double vision. On admission, she had widespread stimulus-sensitive myoclonus involving the tongue and all 4 limbs, with marked excessive startle reaction, which was eye blinking or body spasms to sudden unexpected noise, movement, or touch, which we know as hyperexplexia. There was episodic opsoclonus and prominent convergence spasm on visual fixation. She also had a non-fluent aphasia with oral apraxia, difficulty repeating sentences, and was only able to follow single-stage command. The testing showed that she was positive on the nasopharyngeal swab with the COVID-19 virus. The dimer was mildly elevated. MRI brain, EEG, and CSF were all reported normal, and PCR for the virus in the CSF and oligonucleotide band were negative. And they also did neural antibodies to rule out the encephalitis, which with NMDA, BOG, aquaporin, leucin, and GAD. The patient was treated with the levetiracetam and clonazepam for a myoclonus, and 2 weeks after the neurological symptoms, she also received a course of steroid as for a clinical diagnosis of presumed post-infectious autoimmune encephalitis affecting the cortex and brainstem. Her cognition and visual symptoms improved, although there were ongoing symptoms. The diagnosis was post-infectious probable brainstem and cortical autoimmune encephalitis. So case 3, 52-year-old man presented with a 10-day history of cough, fever, dyspnea, and myalgia. On admission, he was hypoxic and non-invasive ventilation was started. Bilateral chest X-ray were consistent with the COVID-19, and coronavirus RNA PCR was positive. Oxygen requirement increased and mechanical intubation was required. On the 17th of ICU admission, he was slow to wean from sedation. His consciousness level was impaired, responding to pain only, despite a prolonged withdrawal from sedation. He was hyperreflexic with the lower limbs clonus. The dimer was very much elevated, 80,000. However, CSF PCR and antibodies, along with the oligonucleotide band, were negative. Brain MRI demonstrated multiple clusters of lesions in the deep cerebral white matter and cyst-like areas of various sizes, some with the hemorrhagic foci and peripheral rims of restricted diffusion. I'm going to show you the pictures just after the slide. The outcome was slow and still ongoing neurological improvement over 4 weeks with supportive treatment alone. So the diagnosis was acute demyelinating encephalomyelitis with hemorrhage. This is the picture of the patient where this is the first one is a T2, where you can see this whitish, that's just like findings here in the bilateral cerebral hemisphere. And second is a diffusion weighted, restricted diffusion weighted imaging. And then third, this is the what we call gradient imaging or susceptible imaging. You can see the hemorrhagic infraction, visually see the blood in this, and this is the post contrast without any enhancement. Okay, so this is the case of acute demyelinating encephalomyelitis with hemorrhage. Case 4. 47-year-old woman previously well and who worked with a high-risk occupation for COVID-19 presented with a right-sided headache and left-hand numbness. This was preceded by 7 days of cough, fever, and shortness of breath. On the day of presentation, she had persistent severe headache and progressive onset of left-sided numbness, followed by left-sided weakness, including the face. A few hours later, she was drowsy with severe left upper limb weakness, mild left leg weakness, and hemisensory loss. She required 4 liters of oxygen and had lower zone chest X-ray, CT chest changes compatible with the probable COVID-19, as well as a lymphopenia with elevated D dimer. CT head imaging demonstrated marked right hemispheric vasogenic edema with midline set. This is the case that will interest neurosurgeons. The head MRI showed that the patient had a severe right hemispheric vasogenic edema and small range of T2 hyperintense changes in the left hemisphere, marked mass effect with a 10 millimeter leftward midline set, and mild subfalcine herniation. D dimer was not that much elevated, as you can see, and we do not have any CSF results available on this patient. The patient was treated with high-dose methylprednisolone, 1 gram daily for 5 days, and then patient's consciousness level fell after 48 hours. She developed the fixed dilated right pupil, and she had to go to the emergency hemicrania. She received the oral prednisone along with the IVIG. She was extubated 4 days after the hemicrania, and she starts to improve clinically and was able to wait beer with support. The patient was working in a high risk occupation. They didn't mention what kind, but with the brain biopsy finding, they diagnosed the case as a hyperacute demyelinating encephalomyelitis. And again, in contrast to coronavirus type 1, the brain tissue biopsy was negative in PCR. So the case, this is a case of acute hemorrhagic leukoencephalopathy form of hyperacute demyelinating encephalomyelitis requiring decompressive craniectomy. Okay, this is the case 5, and this is one of my interesting. This is my favorite case, in a way that the 58-year-old man who was previously independent, again in high risk occupation for developing COVID-19, he presented with the acute onset of inability to speak and dense right-sided weakness. This was preceded by a 2-day history of lethargy and cough. He was found to be drowsy and unresponsive. Non-contrast head CT showed hyperdensity consistent with the thrombus in the left PCA territory and acute infarction in the left temporal stem and cerebral peduncle. His D dimer was very high, 75,000, and he was transferred to the nearest tertiary hospital for the risk of vasogenic edema and probably herniation and malignant, and with a concern with the malignant middle cerebral artery syndrome. The degree of, because of the due to the degree of established infarction, they could not either do the IV TPA or intravenous thrombolysis, nor the mechanical thrombectomy were considered. So CT angiogram showed a saddle pulmonary embolism, which was managed conservatively with a split dose of low molecular heparin. Patient condition was critical in hyperacute period with fluctuating level of consciousness and tachycardia, but later stabilized. D-dimer was high, as I mentioned earlier, but reduced to 2,800 after 7 days of anticoagulation. She was found to have a lupus anticoagulant, and the patient was discharged to rehab at day 8. And they diagnosed this patient with ischemic stroke with concurrent pulmonary embolism. This case is interesting in a way that patient had this both-sided, if you see this arrow here, pulmonary embolism, and the degree of the massive infarction more than 50%, with the hemorrhagic transformation and the thrombus here. So, there's always a risk that the bleeding will be more with the start of the heparin in case of pulmonary embolism when you have a brain bleed. But here they try to think what is the first thing that is going to kill the patient, and they decided that that's a pulmonary embolus and they need to treat it. Yes, there was a risk for the hemorrhage in the brain, but the pulmonary embolism was the one that needed the urgent attention. So they went ahead and then started the heparin on this. So as you see that I've already shown you, this is on the Sylvian branch, and these are the hemorrhagic foci, and this is the malignant big MCA stroke. All right. So now we've learned about the adult manifestations of the COVID-19, along with the cases that we just discussed. Now we're going to touch base on the children, where the pediatric multi-system inflammatory syndrome linked to COVID-19 has been very upcoming. For this, I selected these 3 papers. The first paper was from the Oxford, London, where they did the study between the April and September. And then the second study came out a few days ago with the 6 months follow-up on that. And third paper was published here in Nepal with help of my team and with the very good faculty members from the teaching hospital. So we also reviewed it, and we also published one paper here for this case. These are all available in the PubMed. So the first paper that I took here was neurological and radiographic findings, which are associated with COVID-19 infection in children. So in this case series, they took the patient between age 8 and 15 who presented with the COVID-19 infection and neurological symptoms at Great Ormond Street Hospital for Children in London, UK between March and May. And the infection was confirmed by PCR, assay of nasopharyngeal swab, and also with the IgG antibodies against the COVID-19 virus. So out of the 27 children who presented with the neurological manifestations on the pediatric multi-system inflammatory syndrome, 4 patients out of 27, 4 is a very high number. If you look at the 14.8%, they were previously healthy, but they had a new onset of neurological symptoms. So the neurological symptoms they had developed were encephalopathy, headache, brainstem, and cerebral signs, along with the muscle weakness and reduced reflexes. So all those 4 patients required ICU admission, and then their symptoms were, again, as I've said, encephalopathy, headache, brainstem, and cerebral ataxia, and meningism. Interestingly, all of those patients also developed peripheral nervous system involvement with a global proximal muscle weakness in all 4 patients and reduced reflexes in 2. MRI brain showed that most of these patients had a splenial changes in all 4 patients. CSF was tested in 2 patients, and they were reported as pretty much negative with acellular and negative PCR finding for the virus or oligoclonal banding. EEG showed that they had generalized slowing, no epileptiform discharges or anything was seen. Autoimmune encephalitis panel were again negative in all patients, similar to our adult patients. And nerve conduction study and electromyography showed that they had a myopathic and neuropathic changes. So in this case series, children with COVID-19, they presented with a new neurological symptoms involving both central and peripheral nervous system, along with this linear changes on the imaging in the absence of respiratory symptoms. So The children can present only with the other different manifestations, and they don't need to have a respiratory symptoms to be diagnosed with the COVID-19. The learning point is that. So all of these patients were treated with the corticosteroids and rituximab, along with the anakinra, which is also a rheumatoid arthritis medications. I think it's a monoclonal antibody. And out of those 4 patients, 2 of the patients had a full recovery and they were discharged after 11 and 18 days. And the remaining 2 remained there for some time and were discharged from ICU, but still remained inpatient and this paper was published last year. And I'll talk about those patients in the following paper that they just published 2 days ago. And they both out there were improving clinically, but remain wheelchair bound due to the proximal lower limb muscle weakness. So the other organ systems that were included were on the patients were gastrointestinal, cardiovascular, hematologic, mucocutaneous, and on the cardiac, they saw that it's a presentation like a Kawasaki disease-like features. So the remark was, because none of the children displayed the severe respiratory symptoms usually associated with the COVID-19 virus, we as the physicians or neurologists were urged to include pediatric multi-system inflammatory syndrome in the differential diagnosis for all children who present with the new neurological symptoms. So the same group followed up the patients for 6 months and published the paper again. And this came out only on May 24th, which is a few days ago, like 3 days ago. So, and what they concluded or what they identified was this pediatric inflammatory multisystem syndrome is a new rare post-infectious complications of COVID-19 infection in children. And all these patients were less than 18 years of age, and they all met the criteria as established by the Royal College of Pediatric and Child Health. And they were followed by a multidisciplinary team of specialists for 6 weeks and then 6 months after the admission. And they were regularly monitored with the biochemical and functional outcomes were analyzed. So this is a table that I wanted to share with you, was to show that the male dominance was higher, 65% compared to the female. Among the ethnicity, in contrast to white race that we saw in the adult folks, we had a very less on white here. African and Caribbean, African Americans and Caribbeans were higher, and also South Asian. And South Asian included Indians, Bangladeshis, Nepali, Pakistani, and Sri Lankans. They were all treated with the corticosteroids and IVIG. So this is interesting that anybody can develop this pediatric multi-inflammatory multisystem syndrome. And they also looked at the interesting physical, emotional, social, and school performance and psychosocial, both on the patient self-reported as well as parental reported. On out of 38 patients, there wasn't much difference on the emotional, social, school. However, we saw a significant difference on the physical scale on the no impairment to no impairment here. And also we saw difference on the psychosocial between the parental reporting and the patient self-reporting. Now, the 6 months follow-up of these pediatric patients, nobody died, but many had residual new deficits. The majority of the patient had severe multi-system involvement during their initial illness. And the most common was the gastrointestinal with a 98%, neurological was 52%, and echo abnormalities, which is cardiac, was mostly resolved by 6 months. So they also saw that the patients had few organ-specific sequelae after the 6 months, where they saw that they had a neuromuscular fatigue with proximal myopathy, dysmetry, and abnormal saccades. And on the psychiatric realm, they noticed that the kids had developed anxiety and emotional lability. Their biochemical markers and inflammation resolved. However, the virus serology Status remained positive in most patients despite immunosuppression. Patients continuously required physical reconditioning and mental health support. Physiotherapy assessment revealed persisting poor exercise tolerance. Longer-term follow-up will help define the extended natural history of the pediatric inflammatory multisystem syndrome. So, what is the take-home message here? We saw that despite a wide range of initial presentation, we had these 5 categories that we started with, and the categories kind of increased, and based upon those categories that could help us to do a proper investigation and treatment. Most of the cases had negative PCR on the CSF testing. Autoimmune forms of encephalitis, which are NMD and Delusion, were negative both in CSF and serum. And encephalomyelitis part, which is aquaporin and MOG, were also negative in both CSF and serum. D-dimers were very raised on the stroke patients, but they were higher to begin with, as they are the inflammatory markers. Those with the encephalopathies improved without specific treatment. One patient with edema made some improvements spontaneously without specific treatment. The patient with inflammatory CNS disease were treated with the steroids in combination of the steroids and IVIG. They had very ill outcomes to date, but the follow-up period was short. 6 of the 7 patients with the Guillain-Barré syndrome had partial response to treatment. Because none of the children displayed the severe respiratory symptoms usually associated with the COVID-19. As I mentioned earlier, we physicians and neurologists are urged to include this pediatric inflammatory multisystem syndrome in our differential diagnosis for all the children who present with the new neurological symptoms in coming days. So now, where do we go from here? So as we all know, the COVID-19 has shaken our medical health system. There have been a lot of deaths of our patients and our healthcare workers, and this is very unprecedented in the modern era. As we know, pulmonary complications have received the most attention, but these are the neurological manifestations that are going to be very disabling, persistent, and common in patients with the COVID-19 who are in the hospital or after the discharge with the persistent symptoms. The whole neuro-axis can be involved in a very wide variety of ways. And although we don't know the exact pathophysiology, we presume that these are mostly immune-mediated. And we have seen that nearly 10 to 35% of the patients continue to complain some form of persistent symptoms which are neurological in nature. And all this compilation of symptoms has been termed as long haul COVID or long COVID. And even though we will have an effective vaccine, and we have an effective vaccine now, there are going to be a lot of millions of people who will have long-term neurological consequences. And all of this burden of care will fall on our shoulders as physicians, and we need to be prepared to take care of that. The socio-economic consequences of these complications are going to be dire. So this is where do we go from now? And these are my references. So I would like to show you the, let me see how I do it. I want you guys to, let me see if, let me guys know if it plays out, okay? This is the video that my team developed during the first wave, and I would want to share with you all. If you can't hear the noise, sound, please let me know. Esna or anybody. Can you guys hear it? Can you guys hear it? Hello?
Yes, sir.
Yes, sir.
Okay, good. All right.
पानी प्रशस्त पिउने है र अनि के तपाईलाई साँच्चै थाहा छैन त मास्क मात्रै लगाएर व्यक्तिगत दूरी कायम नगर्दा भाइरस सर्ने खतरा घट्दैन भनेर
ए दाइ तपाईँ कति नजिक आउनु भएको हो? तपाईँलाई कोरोनाको बेला 6 फिट टाढा बस्नुपर्छ भन्ने थाहा छैन कि के हो?
भइगयो नि मास्क लगाएपछि कसरी साध्य हुन्छ सधैँ यसरी दूरी कायम गर्न?
के रे सुत्ती खुस्क्यो कि क्या हो?
तपाईले मास्क त लगाउनु भएको छ, तर व्यक्तिगत दूरी कायम नगर्दा अर्को नजिकैको मान्छे केही गरी कोरोना संक्रमित रहेछ भने ऊबाट धेरै मात्रामा हावामा आइरहेको भाइरस सास फेर्दा मास्कमा भएको सानो सानो छिद्रहरूबाट धेरै संख्यामा भित्र जाने सम्भावना हुन्छ नि।
ए हो त है?
हो, त्यही भाइरसको संख्याले अगाडिको व्यक्ति कति सिकिस्त बिरामी पर्छ भन्ने कुरो निर्धारित गर्छ।
ओहो, हो र भने यो बारेमा त अहिलेसम्म न कसैले भनेको नै छ न कतै सुनेको नै थियो।
यो भाइरसको संख्यालाई डाक्टर अनि वैज्ञानिकहरूले लिथल भाइरस डोज LD50 मा नाप्दै आएका छन्, जसको वास्तविक नम्बर ठ्याक्कै चाहिँ भन्न सकिएको छैन।
डाक्टर साहब, सजिलोसँग बुझ्दा जस्तै चुरोटको धुवा चुरोट खाने व्यक्ति नजिक धेरै हुन्छ, जति टाढा गयो त्यति नै खतरा कम हुन्छ। भाइरस पनि यस्तै रहेछ है?
अझ बुझ्नुपर्ने कुरो के छ भने नि, प्रमाणहरूले पुष्टि गरे अनुसार केही गरी संक्रमण भइहाले नि जो कुनै व्यक्ति जति टाढाबाट र जति कम भाइरसबाट संक्रमित हुन्छ उसको शरीरले त्यति नै सजिलोसँग कोरोना विरुद्ध लड्ने एन्टिबडी बनाउन सक्छ नि। यसले गर्दा केही गरी भविष्यमा फेरि संक्रमित भइहाले नि धेरै सिकिस्त बिरामी पर्ने सम्भावना कम हुन्छ।
यो कुरा सबै डाक्टर र विशेषज्ञलाई त पक्कै थाहा होला नि है?
छ नि, यो कुरा कोरोना सम्बन्धित विशेषज्ञ डाक्टर अनि वैज्ञानिकहरूले आफ्नो अनुसन्धानमूलक लेखहरूमा भन्दै आएका छन्।
ओहो डाक्टर साहब, निकै धन्यवाद छ है यस्तो राम्रो सबैले जान्नुपर्ने कुरा सिकाइदिनु भएकोमा।
So this was the first one, and let us. Oh, sorry. Okay, this is the another one that we built for to increase the awareness for the folks for the pediatric multi-system inflammatory syndrome.
साँच्ची फर्किने बेला सब्जी लिएर फर्किनुहोस् है।
पापा, बाबा, म पनि हजुरसँगै बजार जाने।
हुन्छ, तर पहिले भित्र गएर तिम्रो मास्क लिएर आऊ। यतिकै त्यसै बजार गयो भने त कोरोना सर्छ फेरि।
म मास्क लाउँदिन।
ए केटाहरूले के मास्क लाउनु पर्यो? कोरोना त हामी जस्तो बुढा पाकालाई पो लाग्ने हो त।
कस्तो कुरो गर्नुभएको आमा तपाईले? के कोरोना मान्छे छानी छानी बुढा पाकालाई मात्रै लाग्ने रोग हो र? मास्क नलगाई व्यक्तिगत दूरी कायम नगरे कोरोना बालकदेखि वृद्ध सबै उमेरकोलाई लाग्ने रोग हो। मास्क र व्यक्तिगत दूरी पालना नगरे त लक्षणहरू नदेखिएको संक्रमित बालबालिका अनि जवानहरूले अझ बढी रोग सार्ने पाइएको छ नि।
के रे, लक्षण नदेखेका संक्रमितहरूले बढी रोग सार्न सक्छन् रे?
हो त, अझै 5 देखि 14 वर्ष उमेरका केही बालबालिकाहरूमा त कोरोनाको थुप्रै फरक फरक लक्षणहरू देखा परेका छन् है। ज्वरो खोकी केही नहुँदा नि एकै पटक शरीरका विभिन्न अङ्गहरू जस्तै मस्तिष्क, मुटु, फोक्सो, मृगौलालाई असर गरेको भेटिएको छ। यसलाई डाक्टर तथा वैज्ञानिकहरूले मल्टी सिस्टम इन्फ्लामेटरी सिन्ड्रोम इन चिल्ड्रेन भनेका छन्।
यस्तो हुने बालबालिकामा कतिको सम्भावना छ नि?
यो अहिलेसम्म निकै संख्यामा नदेखिए तापनि सतर्कता नअपनाए बालबालिकाहरूमा धेरै नै हुन सक्ने अनुमान गरिएको छ। छोरी, कोरोनाले गर्दा केही संक्रमित बालबालिकाहरू निकै नै सिकिस्त बिरामी परेको अमेरिका, युरोप, बङ्गलादेश, यही पाकिस्तानमा पनि देखिसक्यो नि। अहिले खोप वा औषधिको व्यवस्था नहुन्जेल संयम र सतर्कता अपनाउनु नै पर्छ। त्यसैले सतर्क रहनुहोस् र आफ्नो बालबालिकालाई मास्क बिना घुम्न नदिनुहोस्। आफू पनि सुरक्षित रहनुहोस्, आफ्नो बच्चाहरूलाई अनि वृद्धहरूलाई पनि सुरक्षित राख्नुहोस्।
Okay, so sorry. So now I think we have come to the pretty much almost towards the end, and I would like to sincerely thank you, Nepal Health Corps, for organizing this event and the support that I've received from COVID Alliance for Nepal, which I'm also a part of it. I would like to thank them all, and I would really like to thank all the participants who came together. And these are my organizations: Global Nepali Health and Research Center and Nepali League Against Epilepsy. As Esna has introduced earlier in the very beginning of the talk program, Global Nepali GNHRC has multiple international collaborations to improve the education and research for Nepali physicians in US and UK. And Nepali League Against Epilepsy, we established to bring all the epilepsy patients out of the shadows and to give them standard care. That's the reason we established these two organizations. I hope you can find these both organizations in the Facebook as well as YouTube. I hope you'll help spread the word out so that we can take care of more and more folks of our own. So now I will take any questions that our audience has. Please write down your questions on the chat box so that our moderator can read out to us. I think before I do that, I think Dr. Agarwal had asked about anakinra. I mentioned that anakinra is a monoclonal antibody medication, and this has been used in the rheumatoid arthritis. That was what I could tell you about it at this time, but I will get back to you once I have more information. Thanks. So there's
for your valuable words. If you have any questions, you can raise your hands or type the questions in the chat box. The meeting is now open for sharing.
So I have one question from Redmi Note 9 Pro. What is Capo's delusion? So this is interesting. Delusion that the person will start thinking his or own folks as an imposter, like they don't believe that who they are. Is there any treatment protocol for COVID-19 neurological manifestations? There may be, but there are ways that we treat patients based upon the clinical symptoms and presentations, because each patient is different. As much as we try to standardize the protocol, but sometimes the neurological presentations or manifestations become complicated, and we have to modify accordingly. So there is Dr. T has asked, COVID-19 has been seen in newborn 252. I didn't understand that. Don't you think it would be better to include all ages of pediatric group? It is, but these are the two papers, and the recent paper that was published was 2 days ago, and I am not aware of the virus affecting the less than 5 years old, less than 5 years old, but I may be wrong. If you know it, let me know, and I'll be more than happy to read. Why is CSF booster for COVID-19 if it has affected the sinus penis? That's $1 million question, Ashish Kumar Shrestha. We don't know. But as I've said, contrast to coronavirus type 1, we did not even see the type 2 in the biopsy as of yet, nor in the PCR. Okay, so Dr. Bikram Gujral has asked if I could talk a little bit about prolonged unconsciousness in COVID-19. This is very interesting, Dr. Bikram, because I think the way I can think of this is maybe autonomic disorders or central autonomic malfunctioning mostly, because as you have seen in the picture, brainstem are one of the areas which has abundant ACE2 receptors. So I'm not absolutely certain what could cause the prolonged unconsciousness COVID-19, but the best explanation that I can come with my experience and knowledge is probably the brainstem malfunctioning with the viral load on that area of the brain. But I'll try to find it and I'll send you an email. Thank you for asking this question. I heard about study of ACE inhibitors and ARBs being done. Any conclusion? Assis Kanal has asked these questions. I'm not quite sure about the study of ACE and ARB in what context. If you could elaborate the context, I may be able to answer that, but I have no idea which study are we referring to. Please, neurological light on the brain fog. I guess it's non-scientific term. Yes, it is a non-scientific term, but it is very much used in the United States as well as in the European countries. Brain fog, it can happen from multiple reasons, but I'm not the expert on this. Probably, if we do not have any structural findings or objective findings, then I usually refer brain fog to the psychologist who could understand the patient's situation and what's going on, and then refer to the psychiatrist or even the neuropsychiatrist who could actually look into the neurochemicals and kind of try to treat that in a proper way. Pritam Gurum has asked, how many cases of cerebral venous sinus thrombosis is associated with COVID-19? I don't have the number in hand, but I can presume that because the COVID-19 does do the hypercoagulable state, and it has been shown with the sepsis as well as vasculitis, I would presume that venous sinus thrombosis could be higher in number. Somewhere, okay, outcome. What is oligochromal band? It is one of the protein that that's what we see is like mostly in the multiple sclerosis. The breakdown products of the neurons or myelin that comes out, and then we measure that in the CSF. So Swarnima Casey has asked, I think there are a lot of messages, and probably we have a few more minutes here. I'm trying to read as much as I can. Swarnima Casey has asked, in case 4, CSF finding was negative and PSR was negative as well. Does that mean virus infiltration to brain is slow and symptoms appear before positive finding? That's what we saw in the, if you can recall the slide where I showed the purple bar, orange bar, and green bars, we've seen that most of the findings of the central nervous system more than the positive test findings. That's right. There's another question from Rajan Chaudhary who asked, what's the most accepted mechanism behind agousia and anosmia in COVID-19 patient? I could not definitely say what it is, but it definitely seems to be affecting the nasopharynx, where we have most, and then traveling through the piriform plate. That's what I could think of, but I do not have absolute answer for why we lose taste and why we lose smell, because we have seen that happening in other viral infections as well. How to differentiate if the psychosis due to the steroid side effect or COVID-19 infection? It's always it's a good question, but we need to be more vigilant. When did we start the steroids, and when did the COVID-19 infection started? D-dimer test and COVID-19 relation. There is not a very linear relationship or non-linear relationship as per my knowledge, but any inflammation in the body can elevate the D-dimer. Is COVID very bad for age 13? COVID-19 itself is a bad virus, but it does not mean that it can cause problems to everyone. 80% of the folks gets better. So if you are getting better, that's the good news. If not, then please talk to your primary care doctors. Up to which time period we can use IVIG in pediatric inflammatory syndrome? This is an interesting question. So the way IVIG works, we need to know that. So we usually give IVIG in bolus and continuation fashion for 3 to 5 days based upon the body weight. However, IVIG effect would be maximized by 6 weeks. And if we don't see that, you can repeat the second round of IVIG. And then in the Western world, we have also plasmapheresis, and probably we had that in Nepal too. But you don't want to do the plasmapheresis after IVIG because you're going to wash out all the IVIG that you just gave, and you're going to lose a lot of money there. And it's not going to be benefit for the patient. You usually want to wait 6 to 8 weeks before you can think of plasmapheresis or second round of IVIG. How frequently COVID leads to PTSD, preventive measures? This is, I think, like a COVID-19 is very anxiety provoking to everyone. And whenever any healthcare worker or any patients get sick and they come to us, they're always scared because of the mortality that we've been seeing in India and throughout the world. And that's happening now in our country as well. But PTSD also has a definition to meet. So I would not like, no, I do not have a much expertise into this, and I will leave it to my psychiatry friends. How often COVID causes exacerbation of pre-existing neurological disease? If yes, there are these exacerbations reversible? We saw that pre-existing neurological disease actually increases the risk of mortality in the if you get the COVID-19 and if you have a neurological manifestations from the COVID-19. But having the pre-existing neurological disease does not necessarily mean that you always have a high risk of dying. But if you have the COVID-19 and you get better with the COVID-19, yes, your exacerbation will be reversible. So there's another question: is the coma completely a neurological manifestations, or it can be secondary to ARS and subsequent hypoxic encephalopathy? And you already have answered the question actually, Asis, because yes, it can happen with septic shock, or it can happen with the hypoxic encephalopathy. So Roshan has asked, most of the patients suffer from COVID-19 develop prolonged weakness. Does this have any neurological tying, or is just a part of disease in general? So this is a very good observation, and I'm glad that you watched it, because yes, you know, like we also need to understand that ICU admission or prolonged bed bed rest or in the hospital itself can cause physical deconditioning that can cause muscle weakness. But is it secondary to the COVID-19? It could be, as we see that any viral infection can cause weakness for a long period of time. There is not a direct tying, as you mentioned, but we've seen that, yes, proximal muscle weakness and some tremors and other findings with the COVID-19 viruses. So how frequently does the neurological manifestation occurs in vaccinated patients? And could you please enlighten us about any side effects of vaccine on neurological symptoms? This was asked by Sandhya Maharjan. And I do not have the answer about how often the neurological manifestations occurs in the vaccinated patients, because I do not know that answer as of now. But I'll have to do the literature search, and I can get back to you if you provide me the email. Regarding the side effects of vaccine on neurological symptoms, I think they are very much well published, and the benefit outweigh the risk, and I would recommend everybody to get the vaccinated if possible. So let's look at the time. I think we're running short on time, but I will share my email address here, and please, you not know if we could have all your questions answered today, because there are 77 questions that I need to answer, and probably it's hard to read on the screen as well. I'm dropping my email address here to everyone, and please write down your questions, and I'll try to answer them as time permits in coming days. I think that would do the best part here. So I would like to give my screen to moderator, and I think so Esna, you can take it from here.
Thank you so much, sir. Thank you, sir, for giving your valuable insights on neurological manifestations of COVID-19. I think we are good for now. Moving on, I would like to welcome Consultant of Internal Medicine, former Vice President of Nepal Health Research Council, Advisor of Nepal Health Corps, Nepal Health Corps Leadership Council member, and President of Bharatpur Hospital, Dr. Bhojraj Adhikari, to give vote of thanks. Dr. Bhojraj has been assisting Mayor of Bharatpur, Chief Minister of Bagmati Province, and CCMC for COVID response in national and regional scales. Over to you, sir.
Thank you, Isna. Good evening, everyone. Namaste. Hello, everyone. I am so sorry for being late, since I was involved in another Zoom meet in important settings regarding the emergency consultation by the government. I must thank Dr. Ishan Adhikari. I can realize how scholarly the presentation was, because sessions. So on the behalf of Nepal Health Corps, I congratulate, I thank, and I'm all audience are grateful to your fantastic presentation. I am aware that neurological manifestation of COVID is less often discussed, and even more or less given important in the settings of critical care, especially in our part of the world. But your presentation must have highlighted many neurotropic, neuroinflammatory events and hypoxic events. I'm sure you must have highlighted regarding seizure, stroke, neuroinflammatory, demyelinating disorders, and many more. And so now we all people are quite aware of neurological manifestation, and when we go through our patients, we will have more ideas, clues, and pros and cons regarding the neurological manifestations. And in days to come, your presentation will even deepen our knowledge in the neurological field. Thank you so much, Dr. Saab. And I must congratulate and praise to the team of Nepal Health Corps, these young teams, especially Pradesh, Isna, and all others who have been all throughout in this COVID pandemic. They have done a fantastic job. They have initiated telemedicine systems, doctor consultation systems. They have been a part of physical and moral supports to the COVID peoples and to the doctor fraternity. From the half of one of the warrior in the COVID pandemic, as a doctor, we have to have less fear, but more concern to the things going on in this world. And we hope soon we will be able to go through this pandemic, and we'll win it soon, hope. And at last but not the least, I again congratulate Dr. Ishan Adhikari, who has been here for us with this presentation, with his attachment to Nepal and with his presentation in neurological field. And I wish his future more bright and more scholarly. Thank you, everyone. For the audience, I'm seeing a lot of friends on this participant list. I do namaste to everyone and give vote of thanks to the presenter. Thank you.
Thank you, Dr. Bozraj. I would like to request all the participants to help me out with filling the post-course evaluation that I just posted on the chat box. That will help us develop future courses or future webinars for all the participants or more participants to come. And this will also be useful for us to provide to the Nepal Medical Council. Please go ahead and fill out that form. You have already done the pre-course. Now let's do the post-course, and please send it out to you. You can just fill it out over there, and I'll have the information. And I can plan to make similar presentations in the future if you guys have enjoyed this today. And Esna, do you have anything more on the housekeeping besides post-course evaluation? We are going to reach out to you all, those who have registered through the Google Forms with the Nepal Health Corps, and we will provide you with, I think like I will let Esna explain what the plans are.
I think we will give some time for the post-evaluation form for now.
Sure. Let's wait. Let's wait everybody to complete that. That's a wonderful idea. And in the meantime, I can probably we've seen that videos, so probably I'll try to skim through the questions and see if there are anything that I need to. Okay, so I posted that forms again, and probably.
And also, I would like to mention one thing. Like many of the doctors, they had asked me how to register for CPD points. For that, you can go to this link, cpdnmc.org.np. Please, moderators, moderate and write it in the chat box. After going there, you will see the website, and there is a tutorial for doctor, like how can we apply for CPD points. You can go there and watch the video. Thank you.
I think they would have to log into the Nepal Medical Council website and create their profile, and they will just have to mention that which course they have attended. It is already listed under the Global Nepali Health and Research Center. And then the credit has been, and they will verify based upon the evaluation pre-course, post-course, and they will tally their names, and they will provide you with the CPD points. So, all right, then, I think Esna, like we're gonna wait for another 5 minutes probably, right? Okay.
I have forwarded the link for NMC in the chat box. Please have a look at it.
So Dr. Bozraj, you said that you're in what part of the town? कहाँ हुनुहुन्छ तपाईँ? तपाईँ म्युट हुनुहुन्छ क्या?
I belong from Bharatpur. Chitpur. I was just wondering about your experience regarding Chinese have developed. I was in the Zoom today. These Chinese people, diplomacy, the people were discussing there, that they have developed hydrogen oxygen generator. And they have told that it's more advantageous for not only lung, it's also for the brain. Because hydrogen itself is an antioxidant, free radical scavenger. When we mix hydrogen and oxygen as a generator, they have developed a machine and they have given the demo just before coming to this presentation. I was there. Do you have any experience regarding that hydrogen oxygen generator in US?
No, I have not used that on the COVID patients.
Okay. Thank you.
I'm trying to send the link again.
I think I hope everybody had time, or probably we will wait. Whatever you guys think. I have all the time here, so. Please make sure the pre-course and post-course evaluation are done. If not, we're also going to be sending that in the email that you guys have provided us during the registration. Is that right, Esna? Okay.
Please, can you check if the link is working or not that I sent in the chat box? Okay, you can go to cpdnmc.org.np. Okay, I think we are good for now. If the link is not working, you can try some other time later.
सबै पार्टिसिपेन्ट्सलाई मेरो तर्फबाट धेरै धेरै Dhanyavad. You guys came and listened to us. So we'll try to make more of these webinars in the coming days. But I would like to tell you that I'm here in the country now, back home, helping my own patients. So feel free to reach out to me anytime. I have shared you my email address, so don't hesitate. Even medical students, you're more than welcome to reach me anytime through the email. Okay? Asa, Sabala, good night and take care. Esna, you have something to say, Esna? Go ahead.
Thank you, sir, for your valuable words. We have come to the end of our webinar. I would like to thank everyone who made this meeting possible. Special thanks to our presenter, Dr. Ishan Adhikari, our respected sir, Dr. Bhojraj Adhikari, for making your presence, Nepal Health Corps team, Global Nepali Health and Research Center, GNHRC, Nepali League Against Epilepsy, NLAE, and COVID Alliance for Nepal for making this webinar successful. Thank you all once again for coming. We hope to see you again next time. Thank you so much.
Thank you. Namaste and good night.